Good afternoon. Welcome back from lunch. We will now continue with our September 23rd National Vaccine Advisory Committee. Our next panel is a booster protection, booster doses and strategies. With the Omicron component in the COVID-19 vaccine starting in fall of 2022 and the continual emergence of COVID-19 variants, this session will explore the shift in boosting strategy for COVID-19. Our speakers include Dr. Nadine Rufile from Emory University, Dr. Kristen Like from the University of Maryland, and Dr. Andy Peskus from Johns Hopkins University. Dr. Rufile, you have the floor. Your slides are up.
Thank you so much. I hope you can hear me, and thank you also for the invitation and helping with moving the slides. So I'm glad to present early data from COVAIL, the COVID-19 variant immunologic landscape trial, a work funded by NIH with Angela Branch and myself serving as the co-chair. Next slide. This randomized phase 2 trial evaluates the breadth of antibody response after different vaccine variant candidates, either monovalent or bivalent, comparing them to the prototype and the variants, and sometimes prototype with the variants. We had 3 stages in COVAIL, and we're about to start the 4th stage. So we had a stage 1 that included Moderna products, stage 2 that included Pfizer-BioNTech products, and stage 3 that included Sanofi GSK products. My focus will be mostly on stage 1, where we have immunologic data. So for Moderna, each arm had a total dose of 50 microgram. This is the approved Moderna booster dose, and the arms were as follows. First was the prototype, then Omicron and Beta, single dose, Omicron and Beta, 2 doses separated by 2 months, and then Omicron Delta, single dose, Omicron single dose, and Omicron and prototype single dose. Each arm consisted of 100 subjects. The study was conducted in U.S. adult at 22 sites, including vaccine and treatment evaluation units. The study products were given as a second boost, and our eligibility criteria allowed for any prior approved or authorized primary vaccine series and single booster with the intervals between these vaccines as stated in the CDC clinical guidance. The study also included participants with known prior COVID-19 infection, as our goal was for the study population to reflect the U.S. immunologic background. Next slide. So for the Moderna stage, we randomized 602 subjects and 597 were vaccinated. Enrollment was between March and May of 2022. Next. We actually had great diversity, and we also enrolled 53% females. Next. And then we had roughly 65% that were younger adult and 35% that were older adult. Next. We had 53%, again, as I mentioned, they were females. Next. And then we had 20% that had prior infection by history or antibody, and 95% had actually received mRNA products prior to study enrollment. Next. We allowed participants that in the study, if they had at least 16 weeks since last vaccine or dose, and the median interval since last antigen exposure was 24 weeks. So all these demographic and baseline characteristics did not vary between arms. Next. Next. And next slide. All right, so the data I will present today, as I mentioned, is focusing on Moderna stage 1 of the COVAIL study from 2 labs with pseudo-neutralization titers. We also have antigen cartography and antibody landscape provided by Derek Smith's lab from the SAFE program. The vaccines were safe and well tolerated. We had many breakthrough infection reflective of the recent BA4, BA5 wave. But today, just for the sake of time, I will be only showing immunogenicity data. Next slide. So since 80% of our participants were uninfected, the focus of the presentation will be on this subgroup. The early responses between young and older individuals were similar. And again, they were combined for the purpose of this presentation. And since we had a group that had a single dose and then 2 doses, that's the beta BA1 bivalent vaccine arms. So we combined them also to present the day 15 data. So here you can see at day 15, the GMT and the GMFR to baseline for each arm and each variant tested. And as you can see, extreme high level titers against D614G, with commonly ID 50 titers between 16,000 and 22,000. Next slide. For Omicron BA1, D15 GMT, the Omicron-containing vaccines had the higher geometric mean fold rise compared to prototype, with an increase anywhere between 16 to 22 times compared to 12 times for the prototype arm when compared to baseline titers. And but as expected, the titers against BA1 were lower than D614G. Next slide. Again, this is very early data. This is, again, day 15 that we have. But from other studies, the mix and match study from Kirsten Leik and Robert Atmar, you see that boosting with prototype vaccines increase levels to D614G and BA1 very well early on, as we've seen with COVID as well. But there is a rapid decay over time within 3 months, particularly for the Omicron titers. Next slides. So what do we know about variant vaccines and durability of antibody response? This is a preprint from Moderna beta bivalent vaccine with a more durable antibody response that was noted against both ancestral and beta strains 6 months after the boost. Next slide. This is data from the MID 21002 study. So if you want to zoom in on the bivalent prototype and beta, again, with a bit more durable response 6 months later against Omicron BA1 than the prototype vaccine. So we're eagerly awaiting within COVAIL the data on later time points to better understand a key component, which is durability. Next slide. Another way to look at the data is to look at the geometric mean ratio using ANCOVA model. Next slide. One more. Yeah, so just to focus on that. So all Omicron-based vaccines were compared to D614G. This vaccine had a GMR to Omicron BA1 greater than 1.5 relative to the prototype vaccine with an unadjusted lower bound confidence above 1. Next. So this is quite similar to the data shown by Moderna on their bivalent Omicron prototype vaccine. Next. I want to show you the data from the Montefiore lab. I want to emphasize that the data is not yet complete. But as you can see here, the different variants that were tested within the Omicron lineage, BA1, BA2, 121, and BA4, BA5. This is the uninfected participants. Note the lower titer for the Omicron subvariant, particularly BA4, BA5. Roughly a third of those titers observed for BA1. But it's hard to draw conclusion with partial data. Next. This is again similar to what Moderna had shown. This is their day 29. And next, and here particularly against BA4, BA5. Next slide. Just a little bit more on antigenic maps and antigenic landscape. Those are common visualization tools used to update influenza vaccine formulation. So antigenic cartography uses neutralization data to position virus variants and sera relative to each other. So I will show this very briefly for the sake of time. Next slide. So you see the lower landscape is day 1 immunity. The upper landscape is day 15. Anything with Omicron actually acts quite well against BA1. Next slide. Here you can see the day 1 and day 15 landscape for uninfected and previously infected. And as you can see, the day 15 of the uninfected looks pretty similar to the day 1 of the previously infected, giving an advantage to hybrid immunity. And as you can see for both cohorts, really we had Omicron-containing vaccine lifting titers against BA1 the most. Next, so one of the deliverables for COVAIL was to try to position BA4, BA5 on that antigenic map. And we think, again, it's somewhere between beta and Omicron, but quite far from D614G, making the case that it's critical to optimize our vaccine. Next slide. We have several limitations, including the small sample size, not allowing for further stratification by prior vaccination or interval since last antigen exposure. Currently, we don't have cellular or innate immunity data, but it's coming soon. We did not test higher vaccine dose above the 50 microgram, for example, for that particular Moderna stage. Data on future time point and stages are currently pending. And the next stage, which is our stage 4, will test BA4, BA5 vaccine candidates, and we hope to start this the first week of October. Next slide. So just in summary, all strategy tested increased titers to Omicron BA1 at day 15, and that at early data, which is day 15, all combination tested really increased titers against BA4, BA5 similarly. Next slide. This is, again, our focus right now is to look at the 3 months and then eventually 6 and 9 and 12 months data, look at the cellular data. And because we had a high number of breakthrough infection, our focus is to understand better the correlates of risk and protection for Omicron's subvariants. Next slide. Many people to thanks and many sites and lab to thanks across the US. Next slide. A particular thanks to GMID, the SAFE program, IDCRC, and the different labs, FHI 360, MS, and especially our participant that made this possible. Next slide. Thank you so much for your attention.
Thank you, Dr. Rufo. Our next presenter is Dr. Kristen Like from the University of Maryland.
Great. Thank you so much for the invitation to be here. I'm representing the Mix and Match study, which is a study that was funded by the IDCRC, tapping into the vaccine training and evaluation unit system. And we aim to look at homologous and heterologous booster vaccines as the first booster. So just as a bit of background, at the time in April 2021, if you think back, we had 3 vaccines under EUA, and we were worried about flexibility in the cases of unequal distribution or vaccine supply. And there was the additional concern about safety with the adenoviral vectors. And we wondered if we could mix and match, and if we could take, say, the best components of an adenoviral vector, such as cell-mediated immune response, and marry that to an mRNA, which has robust humoral immunity, and you could get an even better response. And so a number of trials went into effect in Europe, studying the primary series, whereby the AstraZeneca was given as a first dose, followed by an mRNA. And you can see on the right that there was superior neutralizing antibodies across the board against the variants of that time, as well as decreased infection. And so by May of 2021, we ramped up tapping into the VTU system. So this was a study that was done in 10 centers across the U.S. with pre-existing contracts for database and regulatory management. And we tapped into David Montefiore's lab for pseudoneutralization antibody and the Suter lab at Emory University for live viral neutralization. We're also doing B-cell memory and T-cell responses, but I'm not going to give those results today. And Robert Atmar at Baylor College of Medicine was my co-chair for this study. So in terms of enrollment, it was quite simple. They had to have self-reported, no evidence of having a COVID infection, as well as having received a primary EUA-approved COVID-19 vaccine. We set an interval of 12 weeks for the boost, primarily because we were instructed to have data by autumn 2021. And we enrolled approximately 50 participants per group, stratified half as being below age 56 and half above age 56. And this was designed to inform public health decisions. So this was the original trial design, which I'll just touch on the results, and then I'll move into our Omicron results, which are a little bit more pertinent. But each trial was essentially stage designed. So For instance, we enrolled 150 volunteers, 50 that received the Janssen primary series, 50 that received Moderna, and 50 that received the Pfizer-BioNTech, and then boosted them with Moderna at 100 micrograms. This was prior to them deciding to go with a 50 microgram dose. The second stage was the Janssen boost, and then the third was the Pfizer. So there were 458 people in the first 9 groups. And one weakness of this is that each stage was approximately 3 weeks behind the preceding stage. So there is some interval differences, and they were not randomized. The results of this were reported in the New England Journal this past January. We've since enrolled 8 additional groups looking at Novavax, looking at the Moderna 50 microgram group, and looking at a bivalent group that received the ancestral strain and the beta strain. Just to touch on the overall conclusions in the New England Journal, what we found is that all 3 booster vaccines led to an anamnestic serologic response against all 3 EUA-dosed vaccine groups. For any given primary COVID-19 vaccine prime, the heterologous boosts elicited similar or higher serologic responses as compared to their respective homologous boost responses, and the mRNA vaccines resulted in a higher antibody response in the first 28 days as compared to the homologous J&J, which had the lowest responses. We had no safety concerns, and we presented this data at the VRBPAC meeting October 18th as an adjunct meeting. They had already voted in the prior presentations. However, on October 21st, both the ACIP and the FDA agreed that mixing and matching of vaccines was safe and should be recommended. So we had direct public health input through the initial stages of this vaccine. What I'm going to touch on now is a sub-study of Omicron results, which were just reported in Cell Reports Medicine this past July. Essentially, what you see across the top are the primary series, so either Moderna, Janssen, or the Pfizer-BioNTech in green. The Moderna had a homologous boost at 100 or 50 micrograms. The Janssen primed group had either a Janssen or a Pfizer-BioNTech boost, and then the reverse was true. The Pfizer prime had either a Janssen or a Pfizer-BioNTech boost, separated by 12 weeks. The immunogenicity summary is going to be through day 91. I'm going to report on pseudovirus neutralization antibodies in all of the volunteers, which are approximately 300 for this subset. We're reporting all D614G results as well as BA1 results, but I will do a subset analysis with some of the other civil lineages. We also have confirmatory live viral neutralization antibody data that I'll report. So first, pseudoviral newts. This is a complicated slide, but what you'll see is there's 6 groups, A through F. A through D are the homologous groups. So A is the Moderna prime, followed by the Moderna 100 microgram boost, and right below it is the Moderna prime, followed by the 50 microgram Moderna boost. Across the x-axis is the results out to day 91. On the y-axis is the log neutralization antibody. In blue is the neutralizing results to D614G, and in orange is Omicron results. And what you can see is that all of the boosters had a robust response at day 29 and then had a natural decay out to day 91. However, if you'll see below, I'm reporting the geometric mean fold difference between Omicron and D614G in the numbers below. There's a red box around 5 of those groups. There was statistically significant reduction or acceleration in the decay of the Omicron response, so that by day 91, the geometric mean fold rise was quite a bit elevated in those 5 different groups. Another way of expressing this is in this cartoon, where at day 29, we had a 3 to 6-fold reduction in D614G and Omicron. If you look out to day 91, the Omicron is reduced by 6 to 14-fold below that of the D614G results. Another finding that we noted is that with the Janssen boost, we saw a stabilization of the decay in D614G, such that the results at day 91 were approximately the same as day 29, or in the case of those volunteers that were primed with Pfizer-BioNTech and boosted with Janssen, they in fact had the highest neutralizing antibody results at day 91, which was a surprise. It comports with the Janssen data, but I think is further evidence that this is indeed a very good boost for the mRNA products. This is day 181 data in one single group. This is the Moderna Prime followed by the 100 microgram Moderna boost. So in this, you'll see that there's a stabilization, so that there is that aggressive decay in the Omicron neutralizing antibodies by day 91, but then it stabilizes. So you still have detectable Omicron neutralizing antibodies at day 181. And this is the one group that we squeezed in prior to the Omicron surge. And you can see that out at day 181 on the far right, there are a couple of volunteers that did appear to have an interceding infection, which may be Delta or Omicron. Prior to this, we only had 3 volunteers in roughly 500 individuals that had evidence of N protein or an underlying preceding neutralizing result for having had a prior COVID infection. So we think that this data is pretty clean and not depicting any intercedent bias from COVID infections. Just touching on the live virus neutralization results, this is the same strategy, A through F. Blue is the D614G, and pink is beta, delta is green, and Omicron is the orange color. And it pretty much comports with what I just described with the pseudo-neutralization antibodies. The correlation was approximately 0.8 with Spearman rank correlation. The results are about 10-fold lower. That may be because of a different cell line that is used for the live virus neutralization, but it essentially confirms the pseudo-neutralization antibody results. Lastly, I just want to touch on the sublineages. This is day 29 results, so day 1 on the left and day 29 on the right. In blue, you see a really robust response to D614G. For BA1, 2, and 3, they have very similar results across the board. You start to see about a 7.5-fold reduction when you get to the BA2.12 lineage. And when you move into the BA4-5 sublineage, you have about a 12.4-fold reduction in the neutralizing antibodies. So that comports to a rough 350, say, neutralizing antibodies as compared to almost 5,000 in the D614G. And if you have been following some of the newer sublineages, I can tell you that the BA275 is roughly equivalent to somewhere between BA3 and BA4, so approximately the BA2.12. And then there's a newest sublineage, which is the BA275.2 coming out of India, which essentially has very little neutralizing antibody result. And so our conclusions are that the vaccine boost, as the first primary boost, substantially increases Omicron neutralizing antibody titers. The boosted neutralizing titers to Omicron, but not prototypic D614G, decline rapidly. The Janssen is better as a prime or a boost with mRNA vaccines than as a homologous boost. And the Omicron sublineages exhibit 5 to 12 times reduced neutralization by the Moderna boost sera. So our next steps are to introduce the bivalent D614G and the BA4-5 Omicron boost, as well as we're moving into assessing mucosal immunity. So with that, I'll leave it at questions.
Thank you, Dr. Like. Next presenter is Dr. Andy Pecos from Johns Hopkins University.
Good afternoon, and thank you all for the invitation to come here and talk about variants and vaccines. And so I'm going to talk a little bit from the virus side of things in terms of understanding what's happening with virus evolution, some of the Omicron variants that are emerging to date. So as a virologist, very much interested in mutations in the virus and how they change activities, I oftentimes start my day with a strong cup of coffee and I'll look at some of the websites that are almost daily updating sequences about viruses. And this is just one example of one, the NextStrain site. Essentially, it's time on the x-axis, and the different variants are color-coded. The important variant today is the orange colors, which are the Omicron BA.5 variant. And it's important to note here that essentially the height of these areas, so the height of that orange area reflects diversity within the BA.5 population. This is an important point to note. So there's a lot of diversity in BA.5 that's out there. We speak of BA.5 in a very homogeneous way, but we study a lot of mutations that happen within these subgroups. Not all mutations lead to major changes, and one of the things that we're interested in doing is really sorting out where those mutations are affecting virus, both antigenic structure as well as virus replication. And again, this is just a reminder slide. This is the Hopkins COVID-19 tracking website. We talked earlier in this meeting about the fact that we've reached 1 million deaths in the U.S. from COVID-19, 95 million cases. That's clearly an underestimate. And as you can see from the red line on the far right of the graph, which lists case numbers per day, we're currently at what looks from this perspective is to being a very low case number, but everybody agrees this is probably a vast underrepresentation of the number of cases that are occurring right now, partially due to testing at home, but a contributing factor is the mildness of diseases that are now occurring in the presence of pre-existing immunity, which simply doesn't cause people to go in and get tested for their COVID-19 status. So as other speakers have mentioned, I've been playing a role in the NIH SAVE program, which is essentially to monitor for SARS-CoV-2 mutations and understand how those mutations are contributing to the evolution of the virus. So this all starts with going through these massive genomic sequence databases, looking for variants of concern that have mutations in different areas that might be important in terms of looking at virus function. But then in parallel, also looking at the numbers of sequences that are in databases to try to get a sense of whether a given variant is increasing significantly compared to other circulating viruses. And then we take these viruses, we generate reagents, and we do a series of studies using animal models, using in vitro assays, and using virus replication assays in terms of to try to address the contribution of these mutations to virus replication and to recognition by vaccine-induced antibodies. Now, it's really important. It's hard to underestimate what I call the Omicron effect, and that's how dramatically COVID-19 and SARS-CoV-2 viruses changed with the emergence of Omicron. So it really changed the way we view SARS-CoV-2 disease. We obviously had significantly increased transmission, coupled with the massive changes in the spike antigenic structure, which led to escape from pre-existing immunity, whether that be induced by vaccination or infection, and then altered disease, which is linked to perhaps altered sites of virus replication. So Omicron was really a game changer in terms of our looking at COVID-19 and SARS-CoV-2 mutations. But it's also important to note, as from my first slide, that Omicron sublineages continue to emerge, commonly 1 or 2 point mutations in the spike protein and in other genes. Rarely are there multiple mutations with a concentration in spike. So Omicron emerged with multiple amino acid changes. It's now undergoing what we call normal virus evolution, picking up 1 or 2 mutations for the most part and slowly evolving and mutating. This is just a schematic to try to illustrate the Omicron mutations. So on the top line in the white or peach color is the sequence of the spike protein of the D614G virus that's been talked about, which is essentially the vaccine strain. I've listed below those the various Omicron sublineages, BA.1, 0.2, 0.4, 0.5, on and on. And the important thing is whenever you see a purple dot, that's an amino acid in spike that has changed between the Omicron variant and the vaccine strain. And in the very center of that graph are the 15 or so amino acids that are really playing a role in terms of vaccine efficacy and protection from disease contributing by vaccine-induced antibodies. So you can see that Omicron is incredibly different from the vaccine strain. But as I'll point out in a bit, that still hasn't resulted in complete lack of recognition of our initial vaccines with Omicron. So despite this massive amount of changes, there's still some antibody responses and other immunological responses that are cross-reacting with the Omicron variants. You'll also see that between the other variants, there are one or two purple dots that are appearing in one versus the other. That's the evolution of Omicron that has happened since it's entered the population in late November of 2021. Sorry. I'm going to end with a few comments about vaccine strategies, again, from a virological standpoint. And the best comparison that I'm going to try to make is at least what we know from influenza vaccination. Again, I'm not trying to say that both of these are completely identical to each other, but we've learned a lot from influenza vaccinations over the many, many years that we've been using influenza vaccines, and we should take some messages from that could apply to our COVID-19 vaccination strategy. So first of all, SARS-CoV-2 spike sequences are diverse. This diversity drives escape from antibodies. Those include those neutralizing antibodies, but also non-neutralizing antibodies, which are very difficult to quantify in vitro, but are clearly playing a role in terms of added protection against SARS-CoV-2 infection in vivo. But those changes aren't simply antigenic changes. Any change in the spike protein also potentially changes the function of that protein, which has implications for how that virus is fit and how that virus replicates. A good example is many of those 15 amino acid changes in the center of the SARS-CoV-2 spike protein also alter the ability of that virus to bind to cells or to enter cells. So escape from antibody is oftentimes balanced by changes in fitness, and not all variants that emerge will become dominant, because even though they may look scary on paper, there may be fitness costs that are associated with those mutations that don't allow that virus to become dominant. And it's important to note that we really don't understand viral determinants of transmission very carefully, but viral transmission is really a critical factor that the spike protein is playing a role in. Now, for future vaccine component selection, again, it's really important to understand that population immunity must drive potential changes in vaccination strategies. And of course, the caveat to this is population immunity right now is very, very heterogeneous. If you think about initial vaccine doses, boosters, infections, all the combinations that can have happened to individuals in the country over that. And then that's just within the U.S. Globally, you have other vaccines, other vaccination strategies, poorer vaccination coverage. Understanding population immunity is becoming much, much more difficult. But again, it's critical to understand that in terms of understanding whether there needs to be a change in our vaccination strategy. And I will mention that I think vaccine choice must be separated from this waning immunity aspect of it, because as was demonstrated here, immunity wanes against different variants at different rates. So it may not simply be the antigen that we're immunizing with, but something about our vaccination strategy that might be changed to improve that waning immunity. And again, future vaccination strategies really have to consider pre-existing immunity, as well as the lack of immunity in some populations. Immunizing people with pre-existing immunity, I'm probably speaking to the choir here, is very different from immunizing a naive population. And we've now moved to a stage where most of the adult U.S. population has pre-existing immunity, and we have to think about a vaccination strategy that optimizes their responses to new variants, and that has to be different from a population that's immunologically naive to SARS-CoV-2. Now, importantly, lack of immunity does play a role in terms of young children and infants, so there need to be strategies that take those populations and get them to safe levels of immunity from COVID-19 as well. Issues of short versus long-term protection. It's a good reminder that the initial vaccination strategy was meant to generate as strong an immune response in as short a period of time as possible. That may not be completely conducive to a long-term protective immune response that lasts for more than 6 months, 9 months to a year. So it's going to be important for us to continue to think about vaccination strategies and schedules as one thing that can be utilized to improve vaccine immunity and the time in which that lasts. Infection as an exposure needs to be considered. We don't recommend infection as a substitute for vaccination, but it happens. And it affects your immune response, and it strengthens your immune response to that variant as well as others, and that needs to be considered in recommendations for vaccination. Mucosal immune responses and protection are really critical, and that sort of moves to that next point, which is protection from infection as well as severe disease is something we need to think about. All of us can say that protection from severe disease is most important. I get asked every time I get on the news or in front of anybody else, what about protection from infection? Because that's what the general population wants, and we should think about strategies to improve that aspect of it. And then finally, there are conversations about imprinting, which is an immunological function that has sometimes been shown to be detrimental for influenza vaccines. I think it's important to note that imprinting, meaning stimulating older responses to older strains of viruses as opposed to newer ones, can be problematic with influenza, but it may not be problematic with SARS-CoV-2 if you can boost those cross-reactive responses to a high enough level. And again, that's another strategy that needs to be considered in terms of going forward with the realization that we have 40, 50, 60 years of influenza vaccination to draw on, but only 3 years of SARS-CoV-2 immunity to draw from. All right, and with that, I'm happy to help take any questions that you might have. Thank you for your attention.
Thank you, Dr. Pecos, and I want to thank all the members of this panel. Are there any questions or comments from those in the room or online? Tim Cook, go ahead.
Thank you for that torrent of data. I mean, looking through it all, and I'm just thinking, okay, the FDA has already come out and said the new vaccines need the bivalents have to have the BA4 or 5. I mean, I look at your data. We don't have any for BA4 or 5 yet, but it seems to me it's probably a reasonable call. I just wanted to ask you, like, how do you feel about that call that they made?
Yeah, so I think that there's a lot of merit in it. Obviously, we don't have the direct data of BA4-5 itself in humans, and that's been a criticism, but I think we're to the point where we can use the neutralization antibodies as a surrogate and have a pretty good bead on whether that's going to work. And so, you know, what we don't know is the B memory cell data and whether we're really actually increasing the breadth of the response across the entire platform, meaning for future strains that come down the pike. And that's what the Colvale study is really aimed at tackling, because we have to stop chasing our tails and have some sort of prospective plan to boost in the most efficient way that's going to have the most breadth of the immune response so that future variants are also going to be covered. And I think that's where we're moving, and that's the trickiest part since this is such a fast-moving virus.
Other questions or comments from those in the room or online? Tim, go ahead.
Just to follow up, based on what you've presented and your research, do you think this is going to head toward an annual kind of vaccination with, you know, reading the tea leaves as to where the variants are going and formulating it sort of like flu?
Want to tackle that one?
Yeah, I think it's, this is on. Yeah, I think it's going to start with really an understanding of how this bivalent vaccine rollout really induces that broader memory response. I think there's a potential with these various platforms to induce better long-term responses than we can with, let's say, the influenza vaccine, simply by the nature of these new vaccine platforms. I think it'll be really important for us to continue to monitor for how these bivalent responses have induced those long-term antibodies levels, and also to measure memory as well. But I think there is a potential for this to not have to be an annual vaccination, but it's really going to take a little bit more research, I think, to really understand how to optimally induce these vaccinations.
Melody Butler online has a question.
Yes, thank you. Thank you very much for very informative presentations. A lot to take away from here. My question would be for either of you, do you see a cycle with the variants? Do you see if there's any external factors that are enhancing or kind of promoting variants occurring, disappearing, dissipating, and reoccurring over time? Anything that we could be doing to focus on perhaps maybe limiting that, or just kind of preparing for the next variant coming out, or a schedule, if you will, of some sort? Thank you.
I have a couple thoughts too. So
yeah, I can. From the virus side of it, I think there's been an amazing amount of convergent evolution, meaning that different lineages are adopting the same amino acid changes or changing the same amino acids, which is telling us that the virus probably has only a limited number of ways to really get around some things with, like, regarding immunity and still maintaining fitness. I think that's why the bivalent vaccine approach is so nice, because it basically covers the trail of amino acids that the virus can be in, but also looks at what the virus is now. And preventing both of those things may also help us sort of slow down the revolution of the virus.
Yeah, and so I would approach this a little bit differently and say that I don't think we're doing a very good job at covering parts of the world where most of these variants are arising, which is Africa and India. So that there's large swaths of the population, both immunocompetent and also immunocompromised, which is a very important population, particularly in Africa with the HIV, where these viruses are allowed to sort of perpetually and continually evolve within the host and jumping out then into populations. And I think if there's one thing that we should learn or maybe focus on moving ahead, is a better distribution of vaccines to the subcontinent of Africa, sub-Saharan Africa, as well as Asia and countries around the world. We're doing a good job, fairly good job in the Western world, but for some of the vaccine controversies. But we really need to focus, I think, now on the rest of the world if we're going to ever get on top of these new variants.
So I was interested in your comment about the Ad26 providing potentially better responses as a booster. And it poses to me the question of whether this is a platform issue, whether a combination of messenger RNA plus different platform vaccines may provide us an advantage, particularly as we see ongoing evolution of the virus. Be interested in both of your comments on that issue.
Yeah. And so the mix and match study was never intended to be group, analysis of groups between groups. But that's, of course, exactly what everyone did. I mean, it was quite obvious that the Johnson & Johnson, at least the antibody response was quite a bit lower than all the other combinations. But we've always been saying that any of the adenoviral vector vaccines are really good in a heterologous platform, particularly if they're following an mRNA vaccine. And while we don't have day 181 and out to 12-month data, my suspicion is that they're going to continue to rise. Now, that's only against the ancestral strain, but those are pretty remarkably high titers. It was a titer of almost 1,500 at day 91, and that's only continuing to rise. So if anything, it might breathe new life into the adenoviral vaccines as a booster.
Jeff Dushin online has a question.
Thank you for these presentations. And I'm sorry if I missed it, and feel free to let me know I missed it, and I'll review the slides if so. But I'm wondering about the Novavax vaccine and what's happening in the context of evaluation of that vaccine as a potential booster dose. And a related question, where are we with understanding other correlates of protection other than neutralizing antibodies against various manifestations of disease? Thank you.
So at least for the mix and match trial, we've added the Novavax. Now, that doesn't have EUA for booster as yet. they're indicated for a primary at this point. But we have results which has just dropped. They've not been analyzed in completion. So we'll have that data quite soon. I forget the second part of the question.
Correlates of protection.
Correlates of protection. So that's always a tricky. So neutralizing antibodies have kind of been the de facto correlate of protection. If you look at the Gilbert study, and there's also a FANG study in the UK. But obviously there's a wide breadth of immune response to these vaccines. And we are doing an exhaustive analysis on B memory cells, which is hopefully going to be available quite soon, and then taking that into single cell RNA-seq and also extensive T memory cell analysis. So those are much more laborious studies, so it's hard to predict what we're going to find, but I think we'll be able to extract some interesting data out of that.
Yeah, and if I may add, this is Nadine. So yes, I mean, unfortunately in COVID, we had a high number of breakthrough infections during the Omicron wave. So we do plan to integrate cellular, innate, and also other quality of the antibody, the non-neutralizing antibody, to really have a comprehensive view of correlates of protection, particularly to Omicron subvariant. Thank you.
I want to thank our three members of this panel. You've raised a lot of questions for us, as well as given us some important information to think about and move forward. Thank you very much.
Thank you.
Our next panel, and we'll ask those that are in the room to go ahead and move to the stage, please. Our next panel is Protecting Rural Americans, Addressing Gaps in COVID-19 Vaccination Coverage. Addressing barriers to vaccination in rural areas is critical to achieving vaccine equity, reducing disparities, and decreasing COVID-19 related illness and death in the U.S. In this session, we'll hear from Latrice Harris from the CDC, Brittany Roy from the National Governors Association, Siman Kasim from the Arizona Department of Health Services, Dr. Matt Willis from the Marin Health and Human Services County Approach, and Dr. Carrie Rath from the Fabulous Ladies Book Club. Hannah Lips was going to be with us, but unfortunately she's out ill, but her slides are available to you for review afterwards. And I see that Ms. Harris, your slides are up. You have the floor.
Yes, they are. Thank you so much. And it is wonderful to be able to present today on this extremely poignant issue of taking a look at disparities in vaccination coverage. It's something at CDC in the COVID vaccination effort that we really were trying to make sure that we were doing very, up-to-date monitoring of how vaccine was not only being distributed, but also, trends in vaccination uptake in urban and rural counties in the U.S. So my presentation today, I'm actually presenting on behalf of colleagues of mine who were the generators of this analysis, and we will be taking a look at disparities in COVID-19 vaccination between urban and rural counties in the U.S. between December 14th, 2020 and January 31st, 2022. We'll move to the next slide, please. So I just want to start at the very beginning of what we already knew prior to actually embarking on this analysis. So at the point that we started this analysis, we knew that this, first of all, was at the very start of the vaccination campaign. So vaccine rollout corresponding with the time about a week later that we actually started to assess our time frame for this analysis. So we knew that COVID-19 incidence and mortality were higher in rural counties in the United States than in urban communities. And we knew that based on case surveillance and hospital data that were coming out of CDC prior to COVID vaccination implementation actually occurring. And these disparities in COVID-19 vaccination coverage between urban and rural communities had been recognized in the past, in taking a look at some of the different trends from our National Immunization Survey and other surveys related to routine vaccination. We knew that we had seen some differences in urban and rural counties, but COVID vaccine disparities were something that had already started to be recognized as you started to take a look at some of the very early uptake COVID data. And so knowing those things, we wanted to make sure that we were taking a closer look at some of the disparities that had been speculated in the COVID-19 vaccine effort, and making sure that we were able to distinguish a little bit more about where these disparities were happening and the characteristics of individuals in which these disparities were being seen. So next slide. So now we'll move very quickly to what we started to find. So first of all, COVID vaccine coverage, the way we defined it within our analysis was with those that had at least one dose of the primary series, the primary vaccination series. So when we're taking a look specifically at urban versus rural for the entire United States as a whole, we see that there was a significant disparity between the uptake of vaccination coverage in urban counties being 75.4%, while in rural counties we were lagging behind at 58.5%. And so, you know, like I said, this is something that we wanted to make sure in very real time we were also assessing different things and factors for why we might have potentially been seeing these disparities and differences in the county breakdown between urban and rural, and making sure that we were also assuring that with our vaccine distribution efforts at CDC that we were getting vaccine out of the door, making sure that there were various vaccination locations and opportunity for vaccination in rural counties as well as in urban. Next slide. So here we see that our gap between vaccination coverage in the urban and rural counties was actually 2 times more than what we had seen in earlier parts of the pandemic. So here we see on our slide, we have between April 2021 and January 2022. And so as we are looking at that gap widen over time, it was really interesting to kind of try to understand what are the characteristics of these individuals in which we're seeing this gap increase. You know, why is uptake in rural counties happening at a slower rate? But then also, like I said, I think the first part of it was trying to identify the characteristics of those individuals in which we're seeing this gap. Again, trying to target efforts on the ground to help impact these changes and address any disparities that we were seeing in vaccination coverage. Next slide. So what we found was that 46 states had higher COVID-19 vaccine uptake in urban areas than in rural areas. Again, this was something that we were seeing it happening in a number of states in the U.S. This was not a unique problem to any particular part geographically of the country. This was just something that we were seeing a lot. And we know that, this COVID-19 vaccination effort has been different in the sense of how routine vaccinations are provided, because a large amount of vaccine was coming through mass vaccination clinics, through pharmacies, et cetera. And so, one of the things that we really were trying to think about is, okay, let's again try to identify the characteristics of these individuals in which you're seeing the differences in urban and rural uptake. Next slide. So we did have one state that had a higher rural vaccination uptake than in the urban areas. And I believe that this difference was slight. Anecdotally, I don't think that Arizona was particularly doing anything different in terms of their vaccination planning, vaccination rollout planning than any other state in the United States. I think that this just so happened to be that Arizona actually does have some very, very large rural counties and individuals who were highly motivated to be vaccinated in those counties. And so you did see vaccination coverage in Arizona that was higher in rural counties than in urban. Next slide. And then we had 3 states that were a part of our analysis: New Hampshire, Rhode Island, and Delaware, as well as the District of Columbia, that have no rural counties in terms of how rural is defined. And so these counties were not a part of our analysis. Next slide. So overall, we found that vaccination coverage was lower in rural areas compared to urban areas across age and sex. So if we can go to the next slide, we'll move to the next. Yes, perfect. Thank you. So as we can see here, male and female differences. In urban and rural counties, we see that females are slightly more likely to receive vaccinations than men. And I think this was something that we saw just nationally, but we can see the breakouts here, specifically in urban and rural counties, with the wider gap being in rural counties where females were 61%, were receiving vaccine at 61.4%, whereas males coverage was 55.7%. We saw similar characteristics in age. Next slide. Yes. So in the 5 to 11-year-olds, of course, this was the age group that received vaccination last. So, of course, you're going to see that disparity there, that vaccine was not actually approved for that age group until a later time frame. And so that, we think, accounts for a lot of the disparity that we see. Of course, we have to have a pattern and time for uptake to actually occur in the lower age groups, and making sure that vaccination is practices are becoming more customary for that group. But it is something that we wanted to point out of note during the time frame, that there were disparities between the lower 5 to 11 and 12 to 17-year-olds. Next slide. And then we saw as well that booster coverage, when we took a look at booster, not just primary series, but booster coverage was similar in both urban and rural areas. So you have kind of this evolution where early on with primary vaccination, primary series vaccination, you see greater disparities between urban and rural counties. But once we moved into the phase of booster vaccination, those gaps tend to close. And so it's very interesting. I think there's a number of different things we may be able to attribute this to. For the purposes of our analysis, we didn't dig into those things. But I think that, as we all are aware, by the time boosters started to actually come out and be available, I think things had changed within the public sphere in terms of an appetite for vaccination, as well as just some of the different vaccination practices that people were choosing for themselves and their families. So I think that, it's very interesting that gap closes in the booster period. Next slide. And so here I just wanted to make sure, after capturing the very high points of our analysis, that we talked a little bit about the methodology and how we were able to actually attain the results from these analyses. So for the very first time, CDC was able to embark on an effort where we were able to collect vaccination uptake information from all 64 jurisdictions in the immunization program, from pharmacies, as well as federal entities, such as the Veterans Administration and DOD, et cetera, in the country. And so immunization information systems were utilized to collect this information at the state level, as well as our vaccine administration management system, which was utilized as a mass vaccination tool and implemented within IS infrastructure, but also utilized within mass vaccination settings. Or we had direct data submission coming in from our pharmacy partners, sending a direct stream to CDC, but also sending that information to IISs and ensuring that states had the information that they needed. We, of course, looked at folks that were over the age of 5. I laid out some of the different places that we took a look at and excluded within the analysis in previous slides. But the persons included in this analysis had to have received their first dose during that December 14th, 2020 to January 31st, 2022 timeframe. And of course, using population sizes that were determined by the census, utilizing that as a stable denominator, and taking a look also at county of residences matching at least one of the 6 urban-rural categories, according to NCHS's urban-rural classification scheme. So, similar methods of analysis that are used when looking at anything related to vaccination. But, I think we were able to home in on exactly where disparities were in urban and rural, and start to, again, give ourselves a place for beginning to understand a little bit more about why those things might be happening in the future. So future analyses include digging a little bit deeper into some of the characteristics and also utilizing things like our National Immunization Survey and other things that can assess vaccine acceptance or vaccine hesitancy, if you will, and reasons why different individuals either didn't get vaccination or didn't feel they had access to appropriate vaccination services. And I think that might be all for my presentation. Thank you so much.
Thank you, Ms. Harris. Next presenter is Brittany Roy from the National Governors Association.
Can you guys, is this working? You can hear me? So I will flag, I'm not that great at slides. That's why you don't have them, partly because I don't know how to put them together. We in the policy space, especially at NGA, we use what I like to call translators. So I say, I need this, and then it happens. And then if they don't do it, then I don't have them. So I have talkers, which I prefer. Maybe not so good for you guys, but hang in there with me and we will get through it together. So like previously stated, my name is Brittany Roy and I serve as the Program Director for Public Health at the National Governors Association. Prior to joining NGA about 2 years ago, I served as the Senior Health Policy Advisor to Asa Hutchinson in Arkansas. So I was there March 2020 when we did our executive order for our public health emergency. And I don't know about you guys, but once this is over, I will need therapy. So I am sure you guys are there with me. How many of you know about NGA? Oh man, it's more than I thought though. Okay, so I'm going to make sure I don't get this wrong. So NGA, founded in 1908 by Teddy Roosevelt, and we've evolved into an organization today that serves 55 governors, that's states and territories. So we have Guam, America Samoa, Northern Mariana Islands, Puerto Rico, and Virgin Islands. And we primarily work to provide bipartisan strategy solutions to our governors. We have two arms, our government relations side, which advocates on behalf of the governor's offices, and then the center side, which is where I sit, where we work to provide policy and their extra set of arms, kind of like a consultancy. My team, the public health team, I say public health is everything. I'm a little biased. It touches everything. So population health, infectious disease, chronic disease, the whole gamut. Y'all are public health people. I don't have to tell you about it. So the center, like I mentioned, we run the whole gamut of the policy for NGA. So enough about that. I'm going to get to what I was brought here to talk about, which is the work that we did on behalf of our governors in collaboration with CDC. It's a cooperative agreement. Focusing on vaccination strategies. Within that bucket, when COVID came, CDC reached out, and I'll say this cooperative agreement, it's a little give and take. We say, this is what we're hearing from the governors, and CDC says, this is what we need, and then we help them figure out how to make it work, because you guys know that this, has been a little crazy here. So the Vaccinate with Confidence, that's the project that we worked on. CDC said, we can't figure out what's going on in the rural areas. I don't know if you guys can tell, I got a little bit of a draw. My state, Arkansas, very rural. And so I was like, this is my zhuzh. We can do this. We can help figure it out. I was familiar with a lot of policy advisors in some of those states, just from working in my prior role. Our team got together and said, how do we increase vaccine uptake in these rural communities? I will point out to you guys that we had, when we put this project up, 3 major themes kept appearing, and that was access, streamlining systems, and communications. By show of hands, how many of you live in rural areas? Oh, nice. Okay. How many of you, so you live in rural areas right now? Nice. Okay. How many of you have a pharmacy near you? Even in that rural area? 4. I like it. It wasn't until I moved to DC that the pharmacy was it's a 3-minute walk, right? It's in the grocery store. it made sense. I know that pharmacists, not advocating for pharmacists here, but it was convenient. So when we set up this project, we reached out. My connection to the governor's office is through health policy advisors. They're the ones making the policy decisions in the office. They're the ones briefing the governors on what to do. And they're the ones that come back and tell us the feds aren't getting this right, or this is the help that we need, etc. So through that, we reached out and said, who in your state do we need to talk to? So it was the immunization managers. It was folks in the gov's office. It was the health department. It was anybody that was touching COVID at the time. So I'll flag for you again that when I moved to DC, pharmacy right across the street. Back home, although I lived in suburb, pharmacy not so close. Folks in my family who weren't not in the city, you're talking 20-minute drive time, maybe 30 to a pharmacy or a vaccination site. You're talking 40 minutes to a medical clinic to receive care. Let's not even get into food access issues and built infrastructure and environment, et cetera. And so that was a lot of what we were hearing. Arkansas, we have a centralized health department, right? So Gov's office, everything trickles down. Not all states are like that. That was a new thing for me coming to NGA. What we saw was that you have Gov's office, you have a health department, but then some states have decentralized health departments. So trying to figure out how to loop in the local health departments with vaccination rollout, et cetera, presented its own challenges. I will flag that through this work, we worked with states to think through how to increase local availability to vaccination. So the Alabama Department of Public Health flagged for us that they were partnering with the State Area Health Education Center office to set up 5 regional vaccination sites. And more importantly, they were connecting those vaccinators to Gov's office to make sure things were streamlined. The Indiana Department of Health partnered with EMS workers to service high-risk homebound individuals who wanted the vaccine administered in their own home. That was something we saw a lot when we talk about like trusted messengers and trusted partners and things of that nature. Again, my family that lives in smaller towns, you trust the people that you see often. You don't trust big government. So if someone is coming in that you trust, whether it's your pharmacist or the EMS person that you bump into in the grocery store, those folks were more likely to receive the information or even consider the vaccine. And then I will flag that another, like trending thing that we saw, we've all heard about this. It was the use of a trusted messenger to combat misinformation and things of that nature. And trusted messenger in the form of not big celebrities, but local hometown heroes, if you will. And then we saw that a lot of our governors used their executive power to remove the policy barriers in the form of scope of practice. So a lot of community healthcare workers, those EMS individuals, and then we saw under the PREVENT Act at the federal level, pharmacists were brought in to help with some of those issues as well. One thing that used to get me, I know on our end, we had a lot of states say, we don't want to open the vial. It's too big. We don't have enough folks coming in. So when we open it, it will go to waste. And so we saw some waiting to like pool the appointments to get as many people in as one day. And then some that maybe just did not give it. And so on NGA's side, we worked closely with the administration to advocate for smaller vials. It did not happen as quickly as we wanted it to happen. And so we saw, like states do naturally, our governors, some of the states began to take creative action and figure out, and I don't want to misspeak here, but somehow they made the vials smaller in the health department to not have waste. I will also flag through the communications piece, and we are continuing this work a lot. And like I said, we do bipartisan strategies. So we had both sides mentioning we have a real communications issue. We have an issue in the way that public health is communicated to individuals who may not have been very involved in public health. So we took that information and said, okay, we'll go out and find behavioral scientists who have done this and are way smarter than the folks working on this. So we found a group, the Behavioral Insights team, who had been working with mayors, and we're continuing to partner with them to help us think through communication strategies and what that should look like, and how we should talk about vaccines, how we should talk about communicable diseases or vaccine preventable diseases, et cetera. And so, again, a lot of information that came out of these meetings is people on both sides did not trust that the information they were given was in their best interest. I will flag, I had some of those individuals in my family just for a natural distrust of government. The more I learned and shared information with them, the more they became comfortable with being vaccinated and trusting that the information that was coming out of CDC and the White House was for the benefit of them. We also saw places like Maryland partner with local barbershops and beauty shops to address vaccine concerns. We saw our governors go through and set up town hall meetings to listen to folks in rural areas and meet them where they are, as we say. And then we also saw that our states worked with localities and county fairs and things of that nature to provide information to their residents. I will flag another issue. So again, with NGA, everything we do is to serve our members. And so that is what I like to call the convening powers of the governors, right? Our governors are really good at saying, this is the problem. How do I fix it? Or I don't know the problem. Tell me how we should fix it. So NGA does the same thing. When we were hearing a lot of these concerns, we worked very closely with organizations similar to ourselves, ASTO, NACCHO, NCSL, et cetera. I will flag that one of the things out of this body of work that we are continuing to work on, not just the communications piece, was just how bad our systems did not speak to each other. So the interoperability was not there. And you'd be surprised, the more we dug into it on behalf of the governor, if you will, the more we realized that even some of the things within a health department did not talk, if you will. I can remember days where I'm like, the hospital bed count didn't update. Why didn't it update? And it's like, well, we checked this system, but that system didn't talk to this system. And then a lot of digging through it. Our epidemiologists, who we used to call our wizards, hate it as quickly as the quick turnaround that we needed for the information. And part of the bigger issue is whether systems did not talk. That's my long-winded way of saying NGA heard those concerns, and we have begun to think through what does public health infrastructure reform in the form of data interoperability look like for our states, as well as the communications piece. we are thinking deeply about what does communicating public health look like in the future. And so we will continue that work with Behavioral Insights team and some other individuals. And I will wrap my time because I don't know how long I've been talking and I want my friends here to be able to speak. But in long story short, if I can take a personal point of privilege, being from a rural state, a lot of these things to me are no brainers. Like, it was before COVID. We knew we had the access issues. We knew we didn't have the resources. And so it should not be a surprise to us that uptake may have been a little slow, whether it was from distrust of government or just because the physical infrastructure was just not there. And I think the work that we did with the states reiterated that. And so we are excited to continue that work to think through how we get our rural states resourced at the same rates as our urban areas. Thank you.
Thank you, Ms. Roy, from a fellow Arkansan as well as the chair. Our next presenter is Siman Kasim from the Arizona Department of Human Services.
Thank you. So I'm Siman Kasim, Health Equity Administrator for the Arizona Department of Health Services, here to talk about being that only state that had the higher rate. And I will say it was a bit more of a spread between rural and urban. If you see here, a little bit of a messy slide, but the 7 very rural counties that contributed to this higher rural rate also had very high social vulnerability index. Do you guys know what that is? Or should I? Okay. Had very high SVI scores with the exception of Greenlee, 0.9 or close to 0.9 and above, and then very high rates population of American Indians, Native Americans, and Latinx Arizonans. So one would expect to see quite the opposite, a lagging in vaccine rates for counties that are very rural, very high SVI, very high minority population. But in fact, we saw the opposite. So like many other states, we did have a data-driven strategy. We have very large counties, as you can tell. So county-level vaccine rate data was not going to cut it. We worked with our GIS team, and we have a data equity coordinator in our office to create a vaccine planning tool for counties. We're a decentralized state, for counties as well as some of our statewide partners. And we also we picked our top 3 opportunity census tracts within each rural county that had the highest SVI but the lowest vaccine rate, and really did a multi-million-dollar media strategy, which included, of course, all the geo-targeting and all the digital, but also included door-to-door delivery of flyers and whatnot, and of course was featured in Spanish. Let's see. And then our vaccine equity coordinator, because we had someone just dedicated to this, was able to provide one-on-one TA to the rural counties, and we had data sharing agreements for that census tract vaccine level data that was protected in Arizona for those partners. So, and that's not too different from most other states. We also mobilized on the ground partners. Arizona is actually where the community health worker, I think you guys probably know what community health workers are, promotoras de salud, which are members of the community, lay members of the community that work and are embedded in clinical settings and public health settings. So Arizona, actually rural Arizona, is where that movement or workforce really got its start. So it's very robust and a very strong tradition there. As well as we, of course, had a CDC disparities grant, but because our more populous counties had their own separate grants, the state grant was exclusively focused on rural and tribal. And so I think that focus really helped energize us there. And then, of course, we had our mobile vaccine program, our vaccine equity task force. We did focus groups all across the state with the Mayo Clinic, as well as some of the universities with ethnic minorities to look at what are the drivers of hesitancy, as well as what would be effective messages for our actual communities in Arizona. And then we worked with the Arizona Center for Regional and Border Health, as well as the Arizona Center for Rural Health out of U of A. But really the story I want to say is that tribes have really driven the high rural vaccination rates in Arizona. And I really want to call that out because tragically, we hear about the, disproportionate morbidity and mortality of American Indian, Native Americans, and Latinx Americans with COVID. But I think what I'd like to highlight really is the strong community response to this in Arizona. So Arizona has 22 tribes. We have the third highest American Indian, Native American population in the country, as well as 28% of our lands are tribal. And even though the MMR came out in March of this year, it's the latest data I just want to highlight from Navajo County, which is one of the largest tribes in the nation and actually spans across more than just Arizona into our neighboring states. The rate out of the Navajo County for 5 to 11 vaccine is 50% versus 31% nationally, as well as the 12 to 19-year-olds, 76% versus 60% nationally. So tribes continue to have a strong success. Why? Oops. So I think one thing to note is that through IHS, tribes really have a strong history of especially childhood vaccination rates in Arizona. So this is really building on a strong historical vaccine rate. Well, you'll see in some cases higher than with white Arizona children, and as well as adult vaccine. Sovereignty of the tribes really allowed tribes to have their own unique responses that were at times more stringent and independent from the state response. Also suffering great losses. So I talked about those high mortality rates. And of course, with COVID was with older Arizonans or older Americans. So that's a loss of elders in the tribe, which is particularly tragic, really across our state. And then the tribes, of course, 22 tribes are 22 different communities, but I think overall there was a choice to have very transparent communication with their communities, sometimes more transparent than you saw across the state. And then I think we've heard to a value system that favors community responsibility. Again, I just want to say, of course, tribes are different and they have different traditions and cultures, but there is sort of a connecting theme around a community-centered value system. So in talking with some of tribal leaders, for example, this is a lengthy quote from Navajo Nation or Diné Nation. Janelle really talked about, we already had on the ground partners mobilizing for flu vaccine pods and had this sort of this sophisticated orchestrated infrastructure. And so that when COVID hit, that really paid off in terms of being able to roll out vaccine in, of course, hard to reach areas if we're talking about rural. Touching on the sort of sophisticated, I would say, campaigns around vaccine really emphasized the more community values. You can see with San Carlos Apache, for you, for me, for all. And then, oops, on the next slide, really using native voices. So rodeo stars for campaigns aimed at youth, campaigns using elders. Really the message, for example, here again with San Carlos Apache tribe was, elders have gotten us to this point. It is up to you now to protect our future. So really culturally relevant messages. And of course, deploying all the best practices in terms of communication, one-on-one assistance and incentives. We heard from one of the tribes that was presenting at our Vaccine Equity Task Force that tribal members would fly in from other states like California to get vaccinated at home. So that's how really impactful I think that those messages really were. This is Tuba City Regional Health Center. Again, featuring Native voices, messages developed by various tribal communities for their own communities, I think was particularly effective and really mobilized strong immunization. Then moving over to the western and southern parts of the state, I'll just touch on before I go, which is, again, really using, working with the Regional Center for Border Health that works along the entire western part of our state, but I'm highlighting La Paz County here because, again, of its very high SVI, extremely difficult to reach population. lots of folks who do not live in traditional housing, lots of folks who, just experiencing extreme poverty. And you can see the very high SVI rate, as well as about 50% of the population is either Native or Latinx. But through the Regional Center for Border Health, which already, again, one of the early folks who to really embed promotoras de salud in their mobile clinic sort of workforce. They had 6 mobile units that are already known to those communities, already go to those communities for regular preventative and primary care. We're really able to dispatch into those communities and make headway with vaccine rates. Of course, they already had a tradition of vaccinating migrant farm workers. So showing up at 4 a.m., showing up at 10 p.m. before and after folks went to the fields to work was another strategy by the Regional Center for Border Health. Down in southern Arizona, University of Arizona Center for Rural Health had its own mobile vaccine program, separate actually from our state mobile vaccine program. And again, when you're working with a community that high incidence of poverty, really targeting essential health workers, migrants, seniors, low income housing is key to penetrating and getting high vaccine rates. And I just want to point out, so down in the bottom is Santa Cruz County. And if you look at our state COVID dashboard, we don't cap it at 95% like the CDC. So we have a 151% vaccine rate, which just speaks to some of the condition in Arizona, which is folks come to Arizona who live nearby across the border, whether it's in California or Mexico, to work. And so the numerator is going to be smaller, but recognizing that the population of Santa Cruz, populations of La Paz, Mojave, Yuma, expand during the agricultural seasons and then contract. And so knowing that you have to hit that workforce is key to getting 150% vaccination. And so that's it. Thank you so much.
Thank you very much. Our next presenter is Dr. Matt Willis from the Marin Health and Human Services County Approach.
Thank you. It's an honor to be here. I want to start by recognizing that I'm representing a large number of people that worked very hard in Marin County to try and achieve vaccine equity, particularly in our rural West Marin community. I'm going to start by offering some context pre-COVID for what our experience in Marin County. We, in 2014, had some of the lowest vaccination rates in the state of California. Only 75% of our incoming kindergartners were fully vaccinated. We had the highest rates of personal belief exemptions against required vaccinations in the Bay Area. We had record numbers of whooping cough cases. And in 2015, when we had measles cases, we were sort of highlighted in national media and in national dialogue as being sort of this, the poster child for this, affluent, highly educated community with low vaccination rates. And in fact, Jon Stewart called us out and said that, those people in Marin County are more afraid of gluten than they are of smallpox. And it was kind of like, touche. But it really stimulated some soul searching for us as a community and some new forms of dialogue. And through a combination of policy and dialogue and access, now we have 95% of our kids coming into kindergarten are fully vaccinated, and we have some of the highest vaccination rates against COVID-19 in the nation. About 90% of our kids from age 5 all the way up to 18 are vaccinated. I can't stand here and tell you exactly how that happened. It's obviously complex, and it was culture change. We basically moved from being a vaccine hesitant community to being a vaccine seeking and vaccine friendly community. Obviously, it had a lot of different factors associated, but we did have a strategy, and we tried to apply a discipline to this that I'd like to share, and how we actually applied that to achieving vaccine equity in Marin County for COVID-19. Sorry, there we go. So the way we've been approaching this, some people call it kind of user-centered design. It was just, I see myself, the local health officer as kind of a bridge between you all as sort of national leadership and households. And the easiest way to sort of tell our story, I think, is to start with a family. So this is a family living in rural West Marin. This is a photography project around highlighting families in this community. And let's just think through together kind of what some of the barriers to vaccine are for this family. Some, language, many are Latinx, technology, transportation, health literacy, trust in government, sometimes around immunization issues, and access to healthcare. So any one of those is significant, and taken together can really feel overwhelming. So this really gets down to our core equity challenge when it comes to vaccine equity, which is we're dealing simultaneously in two domains. One is establishing trust, and the other is practical issues around access. And the question for me is that this is not a sort of an academic question. This is a very practical, real-world question for us. February 2021, the vaccine here, there's that family. What do you do? And we brought that to the community. Basically, we knew that we as government weren't in the best position to answer all those questions, but we knew that the resources might be in the community. To what's been already discussed, the trust that had already been established in that community, we knew needed to work through those partners. And this just shows when we place the family at the center, that the obvious most proximal influences over families in terms of thinking, and also in terms of access, are in the community that surrounds them. And we as a local public health agency have a unique opportunity to influence those who are closest to that family in terms of the community. And you see, state and federal agencies are it's very difficult for federal and state agencies to actually access and gain trust through direct communication with families. That's up to us. So these are the three, we've talked a lot about, establishing partnerships and establishing trust. And what I'd like to do is try and offer some of the specific structures that might be spreadable, the specific strategy we used in Marin. So we formed 4 community response teams, or CRTs. These are essentially community coalitions in our 4 hardest hit communities. One of them was in rural West Marin. And we supported them through CARES Act dollars, one lead agency in that community to rally and recruit other partners within those communities to be vaccine champions and to address very specific issues that might be coming in one community or the other. And we supported those communities as a health department through 3 primary strategies that I'll review. The first was using local data for local action. I'm going to say something very obvious, which is that to close gaps, you need to see them, right? And that's a data issue. So you have to stratify. So our wizards, our epidemiologists, were constantly looking at the data and stratifying it in any way that seemed meaningful, whether it was census tract, gender, race, ethnicity, age, to determine where the gaps were. And we set very clear goals with these community response teams about what we were trying to accomplish. This is an example of the data we brought to the CRTs on a weekly basis. What you see in rows are every city and town in Marin. And we had set a goal that no city or town would be more than 10% behind the county average. So what that did was allowed us to have an equity focus, because you're constantly focusing on the tailing end. We don't really worry so much about those who are ahead. It's not an equality approach. It's not a single approach to the whole community, but it's really constantly focusing and tilling that to shepherd everyone along at the same rate. And we're also stratifying by race, ethnicity, and other categories. The next big strategy was communication. This is our most important strategy for establishing trust. And what this shows is, this is what I see as sort of the sequence of trusted information. Starts at the federal level. Take an example, 5 to 11-year-olds are now eligible for vaccine. FDA, CDC comes down to the state. Rob Schechter talks to me, right? This is our California Department of Public Health. I'm the local health officer in California. It arrives intact and trusted by the local health officer. And then the conversation changes, because that's where we're actually able to have bidirectional dialogue. It's the first time in that chain where you're actually able to engage people in households directly. So what we do at the local level is we set up conversations. So we set up meetings. We actually have dialogue. We're actually able to hear and listen and adapt to say, what does this mean for us as a community? How will we roll this out here? And how can we be responsive specifically to people's concerns? Another important element of communication was just, basically having a structure that we established weekly. So these are the sectors that we had basically, like my deputy health officer, Dr. Lisa Santora, who's incredible, and I spent a lot of time in just these very structured weekly communications with key sectors, with the schools, with law enforcement, with our volunteers, our board of supervisors, the community response teams themselves, healthcare. We met with hospitals and clinics every single week, and just an hour-long meeting to be like, here's where we are with the pandemic. These are the key messages for the week. And I think the most important thing for this was really developing those weekly messages so that we're all aligned, so that family is encircled by the same message, basically, no matter where they go, as much as we can to manage kind of the countervailing influence of misinformation. And then another important strategy was just daily public. We had an email that went out to about 50,000 of our residents who had signed up with daily public health status updates for a while, and now that's weekly. I did a lot of 3 to 5 minute videos just sort of explaining where we were at any given point. Lots of press releases with an atmosphere of just basically open access to the media, like basically never say no to an interview. Doesn't matter how small, doesn't matter who it is, doesn't matter if it's conservative, whatever it is, talk. And then our website and social media. And we think this strategy did help inspire trust. This was just from a Casper. This was a randomized survey in Marin County that was conducted last month. The bottom bar there shows that about 92% of our residents responded that they had either strongly agreed or agreed with the statement, "I trust the information provided by Marin County Public Health." And the fact that this was conducted last month suggests that we may have actually inspired more trust in our community from the way we responded to the pandemic together. The last element is building partnerships. And this is particularly important for rural areas, and I think it's been alluded to already. And it's kind of simple, but effective. And you basically, you got your family, you ask 2 questions. Where do they go every day? Like, where do they go? Just because they're rural doesn't mean they don't leave the house, right? So where are they normally traveling around? Is to the school, do they go to the food bank? Do they go to sports event, whatever it might be? That's your list access, because you've already addressed all the barriers to access there because they're already going there. The next question is, who do they trust, right? Who have they established trust with? And the overlap between those two are your most natural partners for both being champions of vaccine messaging and actually offering vaccines themselves by way of access. And this is what our West Marin Community Response Team organized for us based on this strategy. This was that family in West Marin, and those are the specific sectors in that community where people were actually both getting, sort of vaccine positive messaging and actually going for vaccinations. An example of, what we wouldn't have necessarily thought of without the community response team was the food bank. So a lot of these families, low income, were actually taking advantage of the food bank. Food bank, a very natural partner, but not one I would necessarily thought of from a public health standpoint. And the flow and the very process are very similar. People come, they get the food, and then they go. So you can put vaccine operations pretty easily into that setting. And they're also, offering materials. They're offering foods. You can offer pamphlets, whatever it is, and information. And then they actually become mouthpieces of the messaging itself. So that's an example of how in West Marin, people were getting messages and vaccinations from both trusted and already accessed agencies. And this is just a picture of, a vaccine clinic at a school in West Marin, a celebratory atmosphere. And then some of the messaging that was derived from what the CRT in that community thought would be important messaging in Spanish, showing a resident of that community. These are the results in West Marin. So we had, by August of 2021, 98% of our Latinx residents in West Marin were fully vaccinated. And we saw a corresponding decrease in the disproportionality of cases. Latinx residents were 7 times more likely to be infected in 2020. And that has now been sort of normalized to be about 1-to-1 with their white counterparts. So in summary, achieving high vaccination rates equitably requires a simultaneous focus on building trust while removing barriers to vaccination. In Marin County, we used community coalitions called community response teams and public health to partner, and we advanced COVID-19 vaccine equity together with 3 strategies, using local data for local action to describe disparities and set shared goals to narrow them. We communicated for impact by fostering trust, by listening and learning. And that, I think, was the most important element. If we go back to what changed in Marin County between 2015 and 2020, was a difference in the approach to the vaccine conversation itself, which was actually stepping out of our offices and getting into communities and listening and recognizing that the decision-making It's a lot less about what I think and more about what they think if we're trying to change hearts and minds. No one changes their mind when they feel defensive. And so having a different kind of conversation and then delivering frequent, consistent messages across sectors. And then finally building partnerships, starting with existing circles of trust, especially in rural areas, for both access and messaging and operations. And I want to thank everyone who helped contribute to this slide presentation, but also to the effort itself. And just end with, this has not been, on the ground, for those of us, this has not been easy work. This has been a really challenging couple of years. And if it wasn't for just the support of the team, I think that's another best practice. Should put that as the fourth strategy, is just supporting each other through this and celebrating small successes everywhere you can. Thank you.
Thank you, Dr. Willis. Our final presenter in this panel is Dr. Carrie Rath from the Fabulous Ladies Book Club.
All right, I got a clicker, which makes me kind of happy. Hi, thank you for having me. My name is Carrie Rath. I am going to introduce myself and tell you a little bit about where I live and what I do. And then I hope that I can give you some sense of what we achieved in our community as part of a big volunteer effort. I realize I'm speaking last on Friday afternoon, and I'm standing between you and the weekend, maybe happy hour. So hopefully you'll find it entertaining, maybe a little uplifting. I am a practicing OB-GYN. I work at Lincoln County Medical Center in Ruidoso, New Mexico, which, if you're a little bit familiar with the geography, is about halfway between Albuquerque and El Paso, about 60 miles east of I-25. So you take a left if you're going from Albuquerque, and you drive through a lot of nothing, including a stretch of no cell phone service, and you arrive in Ruidoso. I am one of two practicing OBGYNs there. We serve a critical access hospital with 25 beds in the middle of a care desert with about a 50-mile radius between us and the next hospital. All right. Forgive the fact that I wrote the wrong year. I'm going to blame the COVID time vortex and homeschooling. Homeschooling plays a role in this because it was awful. In the summer of 2020, my husband, Dr. Stephen Rath, who we'll call Steve from here on out because calling him the other Dr. Rath is confusing, was deployed for COVID response with the New Mexico Air National Guard. He is an anesthesiologist by training. He is currently about to be penned as a lieutenant and is the SGP of the 150th Medical Group. He was the liaison between New Mexico's Armed Forces or Reserve Response and the New Mexico Department of Health. In that role, he became acquainted with a woman named Dr. Aja Senzoni, who was the coordinator of the infectious disease response for the New Mexico Department of Health. And in December of 2020, we were headed to that vacation, which was the first one we'd taken in a really long time, to go ski on the side of a mountain, and the phone rang. And it was Dr. Senzoni asking Steve if he had any idea how we could put vaccines in arms in our little town. So we had a number of barriers to vaccine delivery. In Ruidoso, the vaccinations that we were using in the county were being delivered to healthcare workers first through our local hospital. That included our first responders, but they were doing everything they could, putting vaccines in arms, and they could only service those of us who worked at the hospital and the first responders. There wasn't a big enough labor force. The County Department of Health had 2 full-time staff, and they were fully utilized in testing efforts. They had no capacity to vaccinate patients. And supply, the local pharmacies weren't receiving vaccines from their parent organizations, and the reimbursement for them was unclear. Steve's office, interestingly enough, has a minus 80 degrees Celsius freezer because some of the procedures that he does within his office. So we had our location. This is my husband's office. It's built as a straight shot from the front door to the back. You can walk in the front door. You can take your choice of 4 rights into rooms and walk out the back door around to the parking lot where you can wait in your car for your 10-minute waiting time. These are my book club ladies. who we called the day after we got the phone call. This is a group of women, and of course their spouses got roped into it, who are community active. We are teachers, we are vets, we are people who work in the technology sector, pharmacists, and we called for help and said, we'll serve mimosas. Come learn the computer system. We can all give a shot, can't we? And they showed up. And then the supply. The Department of Health had Pfizer vaccines sitting on the shelves that were going to expire. And we were one of the few places that could store them because of this happenstance minus 80 Celsius freezer. So the vaccines could come to us and we could use them. This is a picture of vaccines and syringes in our draw room and me giving one of a bazillion vaccines. We certainly faced several challenges in the process of our vaccine delivery, even though we had the location, the labor, and the supply. First, we started in January in a little mountain town. The elderly population was being vaccinated first, and we had snowstorms. We would set up a vaccine clinic, and we'd have snow and ice. In a town the size of Ruidoso, which has about 10,000 people, typically you can call the mayor and say, Lynn, please help. We need someone to come clear snow and ice. And he did, and they helped provide traffic redirection, control, roadway management. We called local restaurants who weren't able to work at the time and said, can we borrow your heaters? These people are lined up outside and they're cold. And they brought them. And then for patients who were unable or immobile, we actually had vaccine teams who put on their snow boots and went out to the cars and vaccinated them through windows. At the time that we launched, the New Mexico Department of Health had launched a vaccine registration and scheduling system. This was an ongoing system. So we gave our first vaccine, I believe, on January 3rd. It was an ongoing effort. So we ran into some technology problems, of course. One of them was that the codes that were given to us to use as a scheduling tool in a town the size of Ruidoso got out. And before we knew it, we had lines of people who had signed up who were not eligible necessarily to vaccinate. But you don't run them off, probably. You just kind of look at them and keep putting one foot in front of the other and think that every vaccine in every arm helps every person. It's hard to throw people out of your vaccine site. So we didn't do that. This is Liz, who actually she telecommuted with Soundhound in San Francisco and worked on the tech side. So every night she called Chris. It's one of my book club friends, called Chris, who was the computer person, and said, Chris, this is the problem we had today. And so Chris and his team would update the computer system every night. Again, equitable distribution certainly became a challenge in a town the size of ours. I already spoke to the computer registration and scheduling. There wasn't a lot of Spanish language support. That's my mother, who's a retired Spanish teacher, who became our Spanish language support. The libraries were closed. If you didn't have a computer, you couldn't register. Technology is always a double-edged sword. We spent a lot of time on the phone. We spent a lot of time talking to the mayor's office. We set up a call center to help those elderly people who could not register themselves. We had a little bit of political interference from our governor's office, and I am not saying that the governor did a bad thing. But in the process of the codes getting out, there was an article in the paper that said that we were giving vaccinations out of order. And then through some back channel discussion with military contacts with the pharmacists or the pharmacies that were just delivering the vaccines, my husband found out that we were not going to be sent anymore because we were going out of order. So he called someone else in his back channel who he had worked with to get Q-tips from somewhere during testing with the guard and said, that's not what happened. And they said, well, just kidding, here, have some more vaccines. Shortly after we started this effort, we had some big successes, some big wins, and I'll share those with you. New Mexico had an early high vaccination rate. I don't know that we can I don't think we can take credit for it. We were a pilot state, so of course we had some early high vaccination rates. But in our town, we did have quite a large swath of the population who became vaccinated early. In one of our clinics, we were told to run what they called a wet run, which was essentially a trial run of the site to say how many people we could get through that site in a given time. And we were sort of given carte blanche as to who we should vaccinate. Though I hate the term influencer, I'm going to use it. We called the influencers in the town and said, if you'll talk about getting vaccinated, we'll vaccinate you. So come on down. So they did. By January 27th, greater than 8% of our state had received at least one dose. At some point, someone wrote a nice article about us. The Washington Post picked it up. It was then retweeted by Michelle Obama and Glennon Doyle and Reese Witherspoon. I was interviewed by the CBS Evening News with Norah O'Donnell, where I got to cry on national television. And I got to be interviewed by the BBC. We had a tremendous outpouring of public gratitude. We never, ever paid for our breakfast or lunches. We had a Healthcare Heroes Award ceremony from the Chamber of Commerce and lots of tears and thank yous. I can't read this. I'll let you read it. This was my thought. At the end of the day, we fully vaccinated 3,281 people. That's all I have for you.
Thank you, Dr. Rath. And I have to say, having seen those interviews and read the the Washington Post piece, much better in person even than it was in press.
Thank you.
Any comments or questions from the committee members here or online?
Molly Howell has a question.
Molly Howell, you have a question?
Yeah, hi, thank you, and thank you to the presenters. I had a question and a comment. First, Latrice, I was wondering if you've looked at the political affiliation of counties and comparing rural and urban and the political affiliation of the various rural counties and what impact that may have had on vaccination rates. And then my comment is to the minimum shipping quantity for COVID-19 vaccines. And I really think ahead of the next pandemic, which I hope I'm not around to see, but I do think for planning, the minimum shipping quantity when the vaccine initially rolled out was over 1,000 doses, which could have had an impact on getting vaccine to rural areas. And even still today, some of the minimum shipping quantities are 300 doses, which for some rural areas in a state like mine, North Dakota, is a real issue for rural providers.
Hi, yes, Molly. So great to hear from you. And great to be able to say hello, if even virtually. So your question about political affiliation, we did a little bit of digging into political affiliation, but it was one of the things that, we also looked at, not just at CDC, but also did some research as far as other data sources that contain that information. And just from our internal analyses, there is a difference. I don't think we looked at the statistical significance of that difference, but, in many cases, particularly early in the pandemic, political affiliation did have an impact on whether you had higher or lower vaccination rates in different places. So that is something we looked at. I think there's been some appetite to look at that a little bit further at CDC in some of our groups, but, stay tuned for that potential analysis. And you are absolutely correct as far as the minimum distribution criterion that were initially on vaccination dosing requirements, like what was actually being shipped at a given moment and how much needed to be in that shipment very early on. That was something that our distribution team was very actually happy that when those numbers changed, where you could actually send smaller quantities of vaccine out particularly to rural areas that, may not have needed, 1,000 doses in a weekly shipment or something like that. So when we got to the point where we were able to kind of change that allocation and distribution strategy, like you said, you're able to kind of make sure you're meeting the needs of a given community exactly where they are, instead of, kind of making them wait, if you will, until they have an order that's big enough to be able to meet that minimum, criterion that was initially there. So you're spot on there. Definitely agree.
Can I offer just a follow up on the comment about minimum allocations? We had to modify our strategy partway through to reach our rural community in terms of the expectation of productivity of a vaccine team. We had thought that, we needed a certain number of vaccinations per staff to justify that resource. We recognized that the teams were sometimes returning from West Marin having vaccinated like 5 to 10 people, and there might have been 5 people on the team. And initially I was mistaken in sort of saying that's not then an efficient investment for us. But we actually recognized through the advocacy of the community response team, but that was the only way we were actually going to be able to get the people out there. So there is sort of a different logic and a different algorithm that needs to be applied in terms of expectations of productivity.
Thank you. John Dunn.
Thanks. I wanted to thank all of you for those talks. They were all very enlightening to me. Listening to them, I was struck at how often the same basic themes about how you guys approach these things came up, although the details in every single case were really, really different. And that leads to the question that I had. All of you talked about sort of little independent strategies and different things. You specifically called out on one of your slides that one of the things that drove high vaccination rates was sovereignty, and this was in the tribes, I believe, sovereignty and the ability to enact independent strategies. Moving beyond COVID, thinking of all other vaccines and everything else that we try to do collectively, do you feel as though our current setup nationally and statewide and every place for vaccination allows for the degree, I don't want to say independent activity, but for the degree of independent local decision-making about how to get this done, both with the health departments and with the local community? Or are there ways that we could do our vaccination programs globally differently that would help to maximize that? Because that's clearly where the money is with this.
I'll just say, I think really the key to the success, sovereignty, and also just sort of like really community led. So if you look at the Regional Center for Border Health, led by a very dynamic woman who herself was raised by migrant farmers. So I think the health equity principles of power sharing and co-design are really key to successful strategies, particularly around obviously lowering disparity. So I think funding needs to be democratized a little bit. And, as a state agency, we struggle because we're bureaucratic. We have state procurement laws. There are a lot of walls for really grassroots organizations to be able to access our funds. So anything that can be done to loosen or to at least ensure that distribution of funding to, enact community level interventions reaches folks that are really of the community. I don't know if y'all can hear me. Can you hear me? Is this on? Yep. Okay.
We did feel a lot of that when we were putting this vaccine clinic together. We received no remuneration whatsoever, which was a great position to come from, right? We were doing this because we loved our community and we wanted our doors open and our kids in schools and our businesses not to fail. That being said, when you're faced with sort of a distrust coming from the governor's office that we're going out of order or we're doing something wrong, it felt pretty, I don't know, maybe the right word is, I can't think of the right word probably, but I mean, it did not feel great to feel like we were doing something wrong when we really felt like we were just buckling down and putting one foot in front of the other and putting vaccines into people so that we could get this done. while we waited for pharmacies to get spun up where they could do this in a fashion where they got reimbursed. And I agree with you. There is some democratization that needs to happen. And I think there's also an amount of respect that needs to come from people who don't live in my community regarding how we go about policing and delivering things into my community. I realize that's a big ask, but I do think it's a reasonable thing to consider when we're talking about pandemic response and how we approach people who live in rural communities. I mean, we happen to be in a position where my husband and I are both physicians and we're fairly well respected members of our community, as well as the partnerships that we had with a lot of the other people in our community who were decision makers and leaders. And that's not always going to be the case. But a lot of the mistrust, I mean, I don't know if y'all kept up with New Mexico politics at all during COVID, but we have a governor who is a woman who is horribly mistrusted in the south half of the state by the rural people who live in that state. And she's routinely and probably will be again elected by the population center in the center and northern part of the state. So when you're talking about delivering something into the south part of the state that is very rural, very red, and very unhappy with the governor, at some point you have to be realistic about how you're going to go about that, which maybe is that you say, I've identified people in this community that might be able to get this done. Go do the thing.
Brief comment on that. Having come from, clinical medicine for a while before I became public health, and it's been reflected, I think, in the conversations over the past couple of days. There's such an amazing sort of rigor and science that's applied to kind of like, what's the right dose and how do you store it? And like T cell, and then you get to like the messy real world where these things actually happen. And we just had a conversation about whether like the monkeypox vaccine can be administered anywhere but the forearm. And there was like this long debate about like whether or not you can actually do it in the back, and like, to me, that's just an example of like, we're not going to get people vaccinated in the real world unless we sort of understand better how this actually hits Main Street, where it actually hits. And we need to find ways to be more flexible from a regulatory standpoint or whatever we see as kind of the gold standard from a clinical standpoint or a scientific standpoint. And where can we loosen to match the realities of, so for example, like schools, like we could do vaccinations in schools just routinely. We did 20 of our schools in Marin County were vaccinated against COVID-19, mass vax. Like most of our kids got vaccinated at school, not at their pediatrician, because you couldn't get the economies of scale that way, right? The pediatricians, there was just too few of them. So those are examples of, things we did sort of opportunistically around COVID-19, just scrappy and make it happen, to sort of have that kind of percolate back up into sort of national regulatory frameworks where we're able to compromise where we need to for the sake of efficiency.
I want to thank all the members of this panel. This has been a spectacular way to end our meeting today, bring it back to the ground and practically trying to impact the health of our population across our country. Thank all of you for your participation. And I want to thank all the members of our committee and those of us that joined us online. At this time, we typically have public comment. I understand we do not have any public comments on the line at this time. I want to thank everyone for participating in our September 22nd and 23rd, 2022 National Vaccine Advisory Committee meeting. And I want to close us with a round of applause for our last panel.
Produced by the U.S. Department of Health and Human Services.